never has anyone clearly been able to look at the use of estrogen and directly correlate that to breast cancer. Never.
Today, I'm thrilled to welcome Dr. Heather Hirsch to the podcast. Dr. Heather Hirsch is a board-certified internist and a nationally recognized leader in women's midlife. She is the founder of The Collaborative, a concierge integrative telemedicine practice dedicated to supporting women through perimenopause and menopause with evidence-based personal care. She completed advanced fellowship training at the Cleveland Clinic, went on to found the Menopause Clinic at Brigham and Women's Hospital, and served as faculty at Harvard Medical School, where her work focused on women's health, midlife transitions, and the intersection of menopause with chronic disease. Today, through The Collaborative and her expertly trained clinical team, she is helping redefine what modern integrative midlife care should look like. Whether you're a clinician or someone experiencing perimenopause yourself, this conversation is designed to inform, empower, and change the way we approach this transition. Well, Dr. Heather Hirsch, I am so excited to have you on here, and we want to answer all of our questions about perimenopause.
Oh my
so
gosh.
I'm going to get right into it.
Okay, I can't wait.
So can you define perimenopause for us?
Yes. So the best way to define perimenopause is actually to define menopause.
Okay.
So menopause is technically a year of no periods. So after spending 365 days, you look down, that day is menopause, and every day after that, you're postmenopausal. But all the time leading up to that one special day is perimenopause. And particularly for women, it can start 5, 7, or even 10 years before menopause. And so you're looking to see what symptoms are starting in and around that time where your hormones start to decline very slowly, but you notice changes in symptoms, which could be hot flashes, night sweats, brain fog, mood, or you see a change in periods. But not all women get periods like me. I have an IUD, so I don't get periods. So I'm looking for the random intermittent brain fog, irritability, and those clues to let me know that I'm in my perimenopause zone.
Got it. So that's kind of leading up to my next question. How do we know if we are in perimenopause? Like I'm in my early 40s and I think I'm in perimenopause, but I don't have any symptoms. I don't know.
Right, exactly. There is no test that rules in or rules out perimenopause, as I know you know. But as clinicians, when they didn't have great training, there's no lab test that tells you that you're in perimenopause. So this is frustrating for both patients and clinicians. It's really a clinical diagnosis. So the clinician decides. That's what clinical diagnosis means. And so a clinician would make that decision based off of what you're telling me. Have your periods changed? Is there any reason periods may have changed that are outside of perimenopause? Like could there be a thyroid condition or postpartum, etc.? What symptoms are you having? Are they more prominent? Are they cyclic? Because usually things in perimenopause will actually be cyclic. So for me, I notice those night sweats, the brain fog, and the rage closer to my period when my estrogen is dropping really, 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 really low. Even though it normally does that, it's just worse in perimenopause. And so it's a clinical diagnosis the clinician decides.
I love that. And I have plenty of people who come to me where I'm like, I think you're likely in perimenopause. Never definitively, but you're likely in perimenopause. I can probably say definitively as they get much older. And more importantly, I always ask, when did your mom have menopause? And I think that's also an important question to ask is, when did your mom, when did your sister have menopause? This leads to my next question, which is, what are some of the first signs and symptoms women have in perimenopause?
Yeah, so it's really different for everybody, but there are some trends. So again, this could fit you, your patients, or it could not. So the first thing that happens is progesterone will actually decline precipitously while estrogen is still really volatile. What that means is it can decline, but then go up and then decline and then go up. So your progesterone kind of pieces out first. It's like, hey, we're done here. And the main role of progesterone actually is to sustain a first trimester pregnancy by acting like the placenta until the placenta forms. So it's almost as if progesterone's like, I don't think we're having any babies anymore, guys. Out.
Peace out.
So progesterone increases GABA, which is a neurotransmitter in our brain that makes us feel calm. It's kind of like the Netflix and chill hormone. And so when your progesterone's declining, I know you don't have your Netflix and chill hormone, you can feel anxiety and some women will start to feel insomnia. So I'll have women say to me, I have a high-powered job, I'm a fast-paced surgeon, I'm a lawyer, I'm a stay-at-home mom juggling like 3 kids and 3 dogs, and yeah, I have anxiety, but it is out of control. I cannot stop ruminating. I cannot fall asleep. It's waking me up in the middle of the night. So that can feel like the earliest signs of perimenopause. And then most women will notice as their progesterone declines, this can cause spotting in between your periods. So they'll say, I had 2 periods in a month. Maybe they had more like spotting in between 2 regular ovulations, or they had an anovulatory bleed. And so that can happen as progesterone starts to decline, and that's where the change in periods starts to come in. Then later, in later perimenopause, as your periods are now every 2 months, or they're every 3 months, or even further, like every 6 months, now that estrogen that was very volatile is actually starting to steadily decline. And so you get the low estrogen symptoms, which I call hot and dry. So hot flashes, night sweats, dry skin, dry vaginal tissue, genital urinary syndrome of menopause, more brain fog, and more low mood. So estrogen increases serotonin, which is like our happy bonding hormone. Somewhere in between like oxytocin and dopamine is serotonin in my mind. And so this is why as estrogen drops, women can feel rage and irritability while it's very choppy and volatile, but then into menopause can sometimes feel anhedonia, lack of joy, and depression.
Wow. So there's a lot that's happening in perimenopause. Some of the things that people come to me where I'm like, this may likely be perimenopause is exactly that. I'm much more emotional. Things make me cry that I didn't cry before.
Yeah.
I'm getting UTIs that I never got before. I have the same sexual partner, but I'm getting more UTIs.
Right.
And so that's important for not only the patient, but for clinicians to know and to look out for when people are coming to them.
Yes.
That this could be a sign of perimenopause. Now, let's talk about testosterone's role in perimenopause. What's happening to testosterone in perimenopause?
Yeah, so testosterone tends to, again, these are tendencies. So some women will notice actually testosterone increases, and that's actually rarer, but it's actually a sign of stress. So your adrenal glands are kind of getting stressed because they're like, where is the estrogen? So your body will actually secrete some testosterone. This is why someone will start to either like lose hair or they will get the mustache.
The chin hair.
The chin hairs.
Or the acne will start coming
Or
in.
the acne. And that's actually a stress response because testosterone's going up. So it's a myth that testosterone always falls in perimenopause. But for a lot of women, testosterone will start to also steadily decline. And that can help with, testosterone helps with things like libido and sexual function. But there's probably lots of things that testosterone do in the brain, in the bones, in the heart, cardiovascular system, and etc. So women tend to start to notice maybe changes in libido is the most obvious one for testosterone if it's lowering. But again, as we said, it can also go up. And that's where you're just patients tell me, I get in the car because it has the best light and just pluck my chin hairs every morning.
Oh my goodness. I hear that too. I hear that often. And I'm like, okay, this is a sign of perimenopause. Your hormones are all over the place. And it's not just estrogen, progesterone. People forget that women also have testosterone, right? So that also fluctuates in perimenopause. So we have to pay attention to that.
Yeah.
So if our progesterone is steadily declining and our estrogen is all over the place, in perimenopause, is there room for hormone replacement therapy? Are you starting people on estrogen, progesterone, testosterone? What is your thought process on how to prescribe in perimenopause?
Yes, my face's lighting up because I'm like, oh, my favorite topic. We haven't talked about this, yet. And, it's really such a fun thing to do because it's really case by case and individual basis. And we start, when I see patients and when I teach, clinicians how to do this, is actually start by figuring out where in perimenopause or even in menopause is the patient. Are they bleeding? Do they have contraception? Is it okay if they get pregnant? Do they not want an unintended pregnancy? Do they have a uterus or not? These are all questions that first you kind of want to help answer. Those are important just kind of structurally, I guess I would say. And then next you go by what is the patient's most bothersome symptom? And this is my method that I've kind of coined hormone stacking. And what I mean by this is when you start with the patient's most bothersome symptom, you do your best to guess. We don't have precision medicine on this, but say, okay, Poonam, you're feeling a lot of anxiety and insomnia and it's out of control. This sounds like, well, you heard this podcast, so now you know that's low progesterone. So I might then start my patient on progesterone first. Why would I do this? Well, because then she's going to get resolution of the symptoms that are bothering her the most first, and then she's going to start to feel better. So maybe you say, well, I'm having hot flashes and anxiety. I'll say, which one bothers you more? And you'll say, it's the anxiety, like the hot flashes, man, that it's annoying, but like I am usually a highly productive woman. I can think through things, but this anxiety is crushing me. So we'd start with the estrogen, and then we'd stack the other part, which is the estrogen. And maybe we do that 4 to 6 weeks later. And I can get into, I bet your next question is, why would you do that? But separating them can be really helpful in overall treating you appropriately.
Nope, that's exactly what I do. So I completely get it. My next question is, when you start progesterone in perimenopause, are you giving it continuously or cyclically? And why is that important?
Yeah. So again, depends. I bet all my answers are going to be depends, so I'm so sorry. It depends. And really what it depends on is a couple things. But, to kind of make this make sense and to make it easy, first of all, why would you cycle or why would you use it continuously?
Right.
So the cyclic, or like 12 days of the month or half of the month, is the minimum amount that we currently believe we need for uterine protection from unopposed estrogen, primarily postmenopausally. Because honestly, you're still making both of these hormones in in quantities in perimenopause. So we don't want unopposed estrogen for too long of a period if you're postmenopausal. And so if you're starting the progesterone, some women like to take the minimum amount that they need. Okay, so they just want to take the minimum amount. However, for a lot of women, if it helps their symptom, you're going to want to do it. So you're going to want to use that medication every day. And actually, I tend to believe that the female brain would prefer a steady state of hormones. We're not made that way. We're made to go up and down each month, and then wacky in perimenopause, and then kind of really low in menopause. So when in doubt, I tend to have my patients do it nightly, because it tends to be more consistent. It's easy compliance. You don't have to remember, oh no, it's like May 6th. I'm 4 days out of my cyclic progesterone. And so it's just easier. And especially, I see women where it relieves their symptoms, but their doctor's telling it to do it cyclic. So they're like, well, 12 days is great and 12 days is awful. And I'm like, this is crazy. So you can absolutely take progesterone. You can always take more progesterone than estrogen. You shouldn't take more estrogen than progesterone. Some women like to do it cyclically because they might experience their worst symptoms, like me, just leading up to their period at first. And so they'll say, well, then I'll just take it leading up to my period. The rest of the time, I'm fine. And so sometimes you kind of start, but then which is fun for me as a clinician, that it's always a journey. It's a long, long journey. And so I'll see my patients a couple months later, and they'll say, well, I ran out because I started taking it every night. And I'm like, okay, that just means great. We're progressing through perimenopause. So that's why you could do it cyclic or continuous.
Right. So what I hear you saying is that usually in early perimenopause, some people may benefit from cyclic and some may benefit from continuously having it.
You got it.
And then as you get to later perimenopause, many people will probably just benefit from the continuous progesterone and then topping it off with some estrogen.
Exactly. And now there is something I talk about a lot in my courses that I have seen clinically over the years, which is progesterone intolerance.
Right. Let's talk about that.
And,
I've seen it.
When I talk about progesterone intolerance, this is a subset of women. I think about 20 to 30% of women who take Prometrium. They're told it's going to like help them and be this miracle and help them with anxiety and help them with sleep. And it actually makes them feel kind of crummy.
Right.
So what does crummy mean? It could make them feel too tired or gassy or like they have water retention or weight gain. And so this could be progesterone intolerance, and it's kind of strong with the bioidentical progesterone that we love so much. And so they feel really frustrated. In that, I think that we could break this down into mild and then moderate and then severe progesterone intolerance. Some of my patients with that mild progesterone intolerance, they like to do the 12 days of the month because they'll say 12 days is fine, doesn't build up in my system, I can still get my rings off and on, I'm not having too much bloating, and it's fine. So, those are good candidates too for women who like to cycle it even when they're later on into menopause.
So in perimenopause, can we use testosterone? Because so many people are coming to me and they're saying, you know what, we have a decrease in libido. So for clinicians out there, for patients out there, what are your thoughts on starting testosterone therapy in perimenopause?
Yes, let's talk about this, and also we should talk about starting estrogen in perimenopause because we're
100%.
doing.
Yes.
Let's go down the list. So when it comes to testosterone, the first thing to think about in a woman who could get pregnant is if she's on testosterone and she has an unintended pregnancy,
Right.
that could cause virilization of the fetus, which just means bad things that you don't want. And so we want to make sure if you are starting testosterone, it's good practice to make sure that there's not going to be an unintended pregnancy. So usually, couples have already figured that out, or women have figured that out. Maybe they have an IUD, or maybe their partners had a vasectomy. So many different combinations out there. But it's just one thing to think about.
So first thing is when you see somebody who is in perimenopause, I think one of the first questions I ask is, what is your method of birth control? Because we don't want to forget that while we're giving HRT.
Right.
We want to make sure that that method of birth control, because you can still get pregnant in perimenopause.
You got
Unlikely, but it can still happen. So I think that's so important to kind of clear out there. The first question really in this process should include what is your method of birth control? And there should be one on board, because you can very well become pregnant during this period.
You absolutely can. And not only is menopausal hormone therapy not birth control, it can kind of help kick in some ovarian function.
Right,
and as we're thinking about adding in some testosterone to boost that libido, just a good time to remind you that you can get pregnant. And, you can use different forms of contraception that work well or bode well with menopausal hormone therapy. So now that we've cleared that out of the way, yes, testosterone can be absolutely used in perimenopause. There is no reason or body of literature that really says you must wait until menopause. And we do have something called it's a testosterone guideline. It's a global consensus position paper that came out in 2019 about testosterone. And it really finds that the majority of use is in postmenopausal women using transdermal testosterone for libido. Right. But there's really no reason you can have low libido postpartum, you can have low libido in perimenopause. And if you're using testosterone correctly, at physiologic levels, typically transdermally. I know some women do injections and there's other options out there, but if you're doing it under a clinician's guidance who is going to make sure that your testosterone is not going to get too high, and again, reminds you to think about contraception, you can use testosterone in perimenopause.
Okay, that's good for people to know. There's so many patients who come to me whose general physician just does not know that you can give, HRT, bioidentical hormone replacement therapy, and testosterone in perimenopause.
Yeah, well, think about this too. What are birth control pills, if not hormone therapy?
Can we just end that debate right now?
Yes.
I need to ask this question. How much hormones are in birth control versus HRT in perimenopause and menopause?
So I have researched this. This is a phenomenal question. And there's not a clear answer. But we know that whatever is in birth control pills, which is typically ethinyl estradiol in combination with norethindrone or a different progestin like drospirenone, is high enough levels to stop you from ovulating. It will shut down your ovulation. So your little brain is like, gosh, we don't need to make our hormones go like this anymore because there's a lot out there. So it just kind of shuts down, right? So there's probably somewhere in the realm of 10 times the dose of either the ethinyl estradiol or sometimes it's actually the progesterone that's the progestin, I should clarify that formulation.
Because it's not bioidentical.
Right, that's not the bioidentical kind. It's the synthetic progestin that will actually shut off or stop you from ovulating. Whereas postmenopausal hormone therapy will not stop you from ovulating. And you know that if you're listening to this sequentially because you could still get pregnant.
Right.
And in fact, sometimes it actually boosts ovarian reserve if you're in perimenopause. So you might, I'm not saying this is by any means something that they do at, reproductive endocrinology and infertility clinics. But if someone is sort of thinking, I still maybe want this one miracle baby, I'm 41 or I'm 42, but my periods are irregular, MHT is not going to hurt you. In fact, it might help you on your way to seeing someone who can also help you getting pregnant, right? So they're totally different. Totally different. And then if we're thinking about the two, it's worthwhile to also add that the postmenopausal hormone therapy comes in so many different routes.
Right.
It can be transdermal. Now, there is a birth control patch. A lot of women don't use it. It can be a gel. It can be a spray. It can be a ring. It can also be oral. There's so many different ways. The formulations are different. Estradiol in menopausal hormone therapy is totally different than ethinyl estradiol that's in birth control pills. And the other thing is you can't really stack with birth control pills, right? So you're just given one pill and it's got one dose
Right.
of ethinyl estradiol and that progestin in it, and you can't change it. And so those are the main differences between birth control pills and MHT.
So there's hormones in both places, different types of hormones, and likely there may be more hormones, as you said, in birth control than in hormone replacement therapy given in perimenopause and menopause.
And this is a clear example of just our education and biases, right? Because, clinicians, I'm sure, say things like, well, you can't take hormone therapy, or I've heard my patients say, my doctor said I can't take hormone therapy. You know who told me this? Once? Drew Barrymore. Drew Barrymore sat next to me in 2023 while we sat on stage with Oprah and looked at me and said, my doctor said I can't take hormone therapy because I'm still having my period. So this is still, very misguided information.
Right.
But when we go back and we retrain clinicians, like which I get to do in my courses, they
do.
see like, oh, I've been prescribing hormone therapy the entire time. And now I'm going to prescribe actually lower doses that actually have more benefits longer term for women. So it's nice to use those comparisons.
I think that what you said was very key, and I'm going to say it again, that physicians have been prescribing hormone replacement therapy to people. Is it called hormone replacement therapy actually, or hormones? Let's just say that.
Yeah.
Physicians have been prescribing hormones to people that were 16 years old because you're giving birth control. Birth control is a form of hormones, right?
100% in my opinion.
And now all of a sudden you're in perimenopause where your hormones are declining and there is this fear of prescribing when our hormones are declining, and there's going to be a vast array of benefits of replacing, adding in those hormones that are now declining. And I think that's so important to say. We have always been giving women hormones, and we've just been labeling it as birth control.
Yes,
and
100%.
Now we're labeling it as hormone replacement therapy, and there's a big ruckus happening.
Yeah, there's, because again, if you trained, as we did, probably in the time between the end of the Women's Health Initiative, so between 2002 and probably more recently, maybe even 2020, maybe even yesterday, you're not taught enough about this. And there is these inherent biases that these medications are dangerous and they're scary and they increase cancer and they increase heart disease. And we know that those are not true.
Can you say that again? And I'm going to actually ask you directly. Does hormone replacement therapy cause breast cancer? Which is the question I get probably from so many people, friends, family. Does being on hormone replacement therapy cause breast cancer?
Let's actually answer this.
Yes.
Let's put this myth to rest.
Thank you.
Never has anyone clearly been able to look at the use of estrogen and directly correlate that to breast cancer. Never. Now, what there have been in all of time, and we can dissect these, is associated risks. So associated risk means we see women given hormone therapy and then we see breast cancer. Okay, so then the associated connection arises. Well, when we give hormones, we see breast cancer. But we can actually now step back and say a couple things here. Number one, when women in the Women's Health Study took conjugated equine estrogen, which is a different formulation than a lot of women take, it's Premarin, is its brand name, and they took that alone without a progestin, and they took it orally, they had reductions in breast cancer. Reductions. And then when they added the synthetic progestin, medroxyprogesterone acetate, there was a slight increased risk. Now, the increased risk was actually 2 to 4 women. The increased risk was actually 2 to 4 women out of 1,000 women over 5 years who took that oral Prempro. Okay, so 2 to 4 women out of 1,000 over 5 years. This is actually very close to statistically, it's like baseline. It wasn't statistically significant at all. Now, they actually saw in that same study, before we move away, that if you got diagnosed while the study was going and you were in the medication group, not the placebo group, you actually had a lower risk of dying. Why? They caught it earlier. So could it just be because cancer takes years to develop? A lot of people don't know this about me, but I did a 2-year master's degree from Roswell Park in cancer biology. Cancer takes years to develop. If you think that if we gave you estrogen and 6 months later that caused you to get cancer that showed up, that doesn't make any sense because it takes longer. what's more likely, because they see this association, they make this link, it's more likely that you are maybe bound and determined to have this because the risk in the general population is 1 in 8.
Right.
But the estrogen just caused it because there may be a receptor on there to actually grow, but show up faster and get you treated faster. Now, not that we want anyone to have breast cancer, but it's important to think about those steps because then you can see that the estrogen doesn't cause you to have cancer. Now, we'll take it one more step further. When they took out the progestin and they used micronized natural progesterone or prometrium,
Which is bioidentical.
which is the bioidentical, which is the one we talked about. Some women
Right.
actually have some side effects too, right? Actually, they see no increased risk of breast cancer above a woman's baseline. So if you are thinking, I won't take hormone therapy because that will help me reduce my risk of breast cancer, not at all true. And the majority of women diagnosed with breast cancer, because reports show that only maybe somewhere around 5% of women are on menopausal hormone therapy, the vast majority of women who get breast cancer are not on hormone therapy, right? So that hopefully helps your listeners like debunk some of these myths.
Thank you.
Yeah.
Because we needed you to debunk it.
Happy to help.
You just said something very important, and I think that we need to talk about it. All my friends are like, well, everywhere I go, I hear about hormone replacement therapy. Everybody's talking about menopause and perimenopause. But Dr. Heather Hirsch, tell me the stats again. How many people are on hormone replacement therapy right now?
Oh my gosh. So, it's bewildering. I'm gonna tell you what I really think. I think probably between this is just me. I bet probably somewhere around 7 to 10%, and I'm going to include unregulated and pellets and stuff in that number. I think the Menopause Society had statistics that were as low as 2%. I think that was in 2024, which it's not like we're that much farther from 2024. This is as we're filming, it's the end of 25. I think probably it's maybe around 5%. I'm going to throw in a little bit more for people who are taking unregulated medications. Maybe they don't know they're on hormone therapy. Maybe they're on compounded things. What does hormone therapy even mean? Does that mean local vaginal estrogen? Are we including them, or are they not included? Are we talking about systemic? I think it might be somewhere around 7%. This is just my own, and I could be overinflating this, but again, I want to include women who are on unregulated medications. But still, compare that to in the late 80s and early 90s, 50, 60, some reports even say up to 65 or 70% of women were on hormone therapy. And do you know how many women are good candidates for menopausal hormone therapy? In my opinion, which may be, a little different than the textbook, but 80 to 90% of women, if not more, are good candidates. So their discrepancy is still massive.
People were given birth control at the age of 16. Like, here you go, here's a prescription of birth control. It's so easy to get. But now, getting that prescription in perimenopause and menopause, we have this huge debate of whether it's helpful or not. And I think that's important to clarify. I'm going to ask you another question, which I think is important. When it comes to perimenopause, are there certain labs that you are getting? And is there a place for labs?
Yes. Okay, so great question. This is going to depend on a couple of things. It's going to depend on the symptoms. It's going to depend where you are in your cycle, or journey, I should say, perimenopause or menopause. And it's going to depend on your past medical history. So there's a couple things that I think is helpful. Labs have their place, for sure. Because also this is the same time as we're in perimenopause, as our hormones are declining, this is the same time where we develop chronic diseases.
Right.
So I like to check my patients' metabolic panels, their A1Cs, their cholesterols. I want to know their blood pressure. Maybe we're thinking about their weight or their BMI, or we're using some body compositions. Maybe we want to start looking at a DEXA scan, especially if they're 1 or 2 years after not having any periods, or you could still be in perimenopause for years, but be having 1 or 2 periods a year. You still probably should have a DEXA scan at that point.
I recommend a DEXA scan in the 40s.
Yeah, there you go. So
if
you're right
in your
with
40s,
me.
let's get a DEXA scan. Let's see what's happening to your bone density, because most people's vitamin D and K2 is going to be low, and that's a great time to get that in.
Yep.
It kind of motivates them to do strength training. Do you have beginnings of osteopenia, osteopenia or osteoporosis. And I think that's really important information to have in your 40s, because that's a great time to start doing something about it, where it can actually be very impactful for your 50s and 60s and 70s.
Yes, I was going to add vitamin D level on there. And then some patients, again, depending on if they've got a lot of endocrinopathies, if they've got rheumatologic conditions, connective tissues, we might order a bigger panel. But again, this is why I wanted to write the Perimenopause Survival Guide, because like, again, if you can think about this before you maybe get hit by the Mack truck, which would be menopause.
Right.
But for many women, perimenopause is even worse. And then by the time they realize like, oh my gosh, like it's kind of behind them. And now they've developed like years of bad sleep that's like really hard to undo, right? So labs. Now, what about hormone testing? This one's a little dicey and it's confusing. But what I like to do is at least tell my patients that your lab work is very it must be taken into context.
Right.
Where are you in your cycle? Are you perimenopause or menopause? Did you take your HRT? Did you not? Are you on it? Are you not? Did you have PCOS? Did you not? So labs are helpful. Some women love numbers and they love their labs, and I will never, say, no, we can't look and see what your body is doing. But I want them to be, understand that there has to be some context behind them, right? I'll have a patient in perimenopause, great example. I started her on a patch because you can also add estrogen in perimenopause. We've talked about that at this point, right? So I started her on a patch. Her periods were like every 6 weeks or every 8 weeks. Maybe sometimes it would be 2 weeks, then it would be like 8 weeks, 16 weeks, 2 weeks. She was having a lot of symptoms of feeling hot and dry. She, after a while, added in some progesterone and she was feeling better. So she's like, let's check my labs. She calls me and she's like, my estrogen is 560. I'm like, girl, that's your own estrogen. Like the patch isn't really giving you an estrogen level of 500. And then I was like, I bet probably in 2 weeks you might start bleeding. And sure enough, she did. And so it's really helpful in context, because otherwise it can be really scary and make no sense. And so, that's kind of my thing when we're talking about moving from like metabolic lab work, which I think it has a perfect place in perimenopause, because this is where you build generational health right here. But then when we're talking about hormone labs, what's their role? Again, just making sure you're in context with your knowing, explaining to your patients that it could also be like useless information.
And when you get them done is important. Like if I'm doing hormone labs, I say, if we're going to look at it, let's try to get it on day 3 of your period. Let's look at that FSH. Look at the estradiol and the progesterone and the free testosterone and see what's happening. And timing of when those labs are done matters. Day of your menstruation matters. And then how you interpret those labs matters. So the clinician's education at this point does matter, because you need someone who can read the labs and put the entire picture into context. And I think what you said is super important. Looking at the patient holistically, there are a lot of changes that are happening in our 40s, right? Some people have beginnings of metabolic disease, like diabetes, prediabetes, cholesterol's changing. And this is really important. How does declining estrogen play a role in changes that people see in hemoglobin A1C, so in their metabolic health, and in their cardiovascular health and cholesterol? I have tons of people who are like, I never had high cholesterol, and boom, I turned 45, and now I have high cholesterol. My hemoglobin A1C is climbing up now. Why is that happening? At the time when the hormones are declining? What role does estrogen play there?
I love this question, and you may not know this about me, but I actually have done research in this area. I actually looked at proteomics of women who were in the WHI, who were on the estrogen or the medication arm, and then in the placebo arm. And what we see is it's clear that women who took estrogen had less progression to diabetes. It actually helped their insulin resistance, or actually I don't want to say help their insulin, it made their insulin more sensitive. That's what I'm trying to say, right? It helped their insulin sensitivity. You want to have a sensitive insulin levels that act quickly and then don't lead to elevated insulin levels and then resistance and then diabetes. So what we see in women who take hormone therapy is there is a link between your estrogen hormone and your insulin hormone. Now, the way I've started to think about this is that they like kind of talk to each other and they keep each other in check.
I think all of our hormones
talk to each other,
right?
For sure. It's probably way more complicated than just estrogen and insulin.
So I think the specialists also all need to talk to each other, the endocrinologist and the OBGYN, because our hormones are all talking to each other. So
all talking to each other.
Another story, yes.
And so what we see is that actually, now this is again an association, but it's pretty strong that as estrogen starts to decline, women will start to develop an increase in insulin resistance and therefore lead them down the path of prediabetes and diabetes if they don't catch it earlier, right? So this is exactly where those declining hormones intersect with the development of chronic diseases. Now, later, and then like I think also through that gut mechanism, you start to get an elevation in lipid profiles as estrogen is declining. And there's less clear pathophysiology of like how that happens. Is it something that like it causes the steroid hormone to just sense less so it makes more? I'm not sure exactly what the mechanism is, but it is so common that we see elevated lipids in perimenopause, or as women are going from the peri to menopause transition. And it's wild to me. So I remember I was speaking at a conference, and whenever I go speak to endocrinologists, I'm like, can you believe that like this could be preventative medicine for prediabetes, hormone therapy? Now it's not, just to be clear. Hormone therapy has 4 FDA indications: hot flashes, night sweats, vaginal dryness, genitourinary syndrome of menopause, and osteopenia and preventing bone loss. But there's clear data that it helps to regulate A1C levels. And also, I think the lipids is, to me, there's more to the story here. I think it's a little complicated because I will see women get started on estrogen and their A1Cs will get better, but I don't always see their lipids get better. Sometimes I do, so it's complicated.
Sometimes I've seen it.
Yeah,
and I think
for sure.
If you're in your late 30s, early 40s, get all your labs done, because we now know that hormones play an important role in your metabolic health. So whether you prediabetes, diabetes, risk factors, and they play an important role in your cardiovascular health, so in your lipid panel.
Yeah.
So I think hormone replacement therapy is not only great for all the symptoms that we're feeling, but it can be protective, potentially protective.
Right.
For your metabolic and your cardiovascular health. And I think that is so important to talk about. And I let my patients know that, listen, you can see that this is happening, and hormone replacement therapy can help.
Exactly. And so, to expand upon that further, metabolic syndrome is, the combination or compilation of elevated A1Cs or diabetes, dyslipidemia, elevated lipids, weight gain and obesity, as well as hypertension and blood pressure. Now, I've also seen women on hormone therapy help reduce their blood pressure. Right. And so we could talk about that. But I think, again, basically, when you're having a hot flash, your vessels are just squeezing and then releasing and then squeezing and then releasing. Like, of course, that's going to increase your blood pressure. Or you're not sleeping, you're tossing and turning. That's going to increase your blood pressure. Right. So when we see this metabolic syndrome and this array of things that can happen all declining, that's why we see for women who start hormone therapy within 10 years, reductions in cardiovascular disease and longevity, right? So this is where we got to really meet. Yeah.
I love that. Talk to me about Alzheimer's and HRT.
Yeah. Okay. This is a great question, right? Because there's lots of things flying around like, does it really decrease the risk of Alzheimer's? The truth is that we don't know yet, okay? The hypothesis is probably, and the mechanism would be because estrogen is a vasodilator, and that's also why it helps blood pressure, right? So it opens up the blood vessels, you get better blood flow, you don't have to work so hard to pump blood through the heart, right? And it acts as a vasodilator, and it acts as an anti-inflammatory mechanism when it started earlier, either in perimenopause, another reason why you could start it earlier, or earlier in the menopause transition. And so think about your brain. Wouldn't you want better blood flow and an anti-inflammatory impact on the brain? Think about how many receptors there are for estrogen in the brain, right?
So many.
There
are estrogen receptors all over our body, and I think that's important to talk about as well. We have estrogen receptors all over our body. So when you add in estradiol, you're actually putting it in different parts of your body, which is helping where we've lost estrogen.
In every organ system. So, the hypothesis, is that most people think it reduces, it's going to help improve brain function. And then for those of us who see patients and we start an HRT, we see their cognitive, improvements, it's easy to see.
Brain fog improves. They have more mental clarity. They remember things.
I mean, I will speak for myself. One of my biggest symptoms is brain fog and word finding difficulty, which is really embarrassing when you're on a podcast or you're on a stage and you're a doctor and you can't remember the word like pump. And wow, does it really change? I mean, I can tell if I forget it, I can feel the brain fog coming in. My suspicion is this. You can mark this as my hypothesis. this will probably be something very similar to diabetes, where what we'll find is that it decreases estrogen, just like I said before in your previous question, decreases the diagnosis to diabetes.
Right.
But we don't say prevents it.
Right.
And I think the same thing may be true, that estrogen may, decrease the diagnosis or the timing of Alzheimer's or neurocognitive decline, but probably no one's going to have the study or the FDA approval. No one is going to do that. So I think kind of just lollygagging around and saying like estrogen prevents Alzheimer's, that's a very like clickbaity thing.
Right.
But research so far is absolutely promising. The hypothesis, as that early promising research comes out, we're like, those of us who do this all the time. But we don't want to jump the gun because we want to be as honest with
Right.
with patients, with viewers as we can be. So that's the TLDR right now as it stands on estrogen and brain function.
Okay, well, thank you for that clarification. I get asked this a lot. Why am I gaining weight in my 30s and 40s? I'm doing the exact same thing, same workout, eating the same, but now I have this little pouch in my stomach or I have this extra weight, extra few pounds, 5 pounds, 10 pounds I didn't have before. Why is this happening? And what can we do in perimenopause so that doesn't happen or that weight goes away?
I mean, such a great question and probably so multifactorial.
100%.
The first thing, and I know you appreciate this, I really do want to ask my patients, of course. One, okay, we cannot deny the impact that hormones will have on shifting adipose tissue.
Right.
Sometimes women will find that they don't actually, maybe they are gaining weight or the number on the scale is going up. Sometimes it's not. It just feels like your body feels different, right? You may actually weigh the same, but your pants feel different, or you might feel the pooch. Yeah. And we all say weight gain, but it could be water retention. It could be constipation. And so I want to also think about how is your sleep, which is, again, your body is kind of doing its dialysis while you're sleeping, and movement. Because even though we say we're moving the same, we forget if a woman has little kids or nieces or nephews, like you very much don't realize how much you move. You go up and down the stairs and up and down the stairs and up and down the stairs and carrying the laundry and bringing back up and then their toys and then carrying the baby.
I have a 1.5-year-old. The amount I carry him, that's an extra like 20-something pounds.
My kids stand on, because they think the scale is fun. So my little one's like, I weigh 45 pounds. I'm like, dang, Brody, you weigh 45 pounds. Because I'm thinking to myself, exactly, right? So there's a lot of things that happen. There's a lot of things that change that it's hard to account for, and we're not really good like narrators, or we don't really remember. And then of course the hormones are going to play with your insulin. They're going to play with your hunger hormones. They're going to play with all of those different hormones, and so adipose tissue tends to shift. And perhaps also too, evolutionarily, like maybe grandparents were meant to do other things, right? Maybe there's a reason for that. Now we don't like it, and there's definitely things that we can do, right? You could talk about, again, all those things from your sleep to your diet to your protein to your movement. We need a lot more protein, as I know you know, and hormones, and of course new medications and things like that. But there's probably a lot that goes into it.
My next question is, talk to me about postpartum. I honestly felt like I was in menopause after I gave my baby, and that's kind of true. So can you do a deeper dive into that for me? Am I experiencing a mini menopause after I give birth? Because what's happening to my hormones after I give birth?
The short answer is yes. In fact, I think I saw you like really, I think we had an event together.
We did.
Right after the little one. And you're like, I'm in my mini menopause. Yeah. Or maybe we even talked about it then,
and,
right?
I tell all my friends, I was like, we've all gone through menopause already. If you gave birth, you went through a mini menopause.
Yeah.
So can you help explain to our listeners what that means?
Yeah. So again, like after you give birth, your estrogen is going to plummet from a really, really high level, which can feel a lot like perimenopause with sort of those volatility and that fluctuation, right? And then your progesterone will also go low too, because actually the kind of hormonal reproductive stuff is just kind of like humming along, especially if you're going to be breastfeeding. And then so that might prolong it, right?
And you don't even get your period. I mean, I didn't get my period till a good year into breastfeeding?
So a lot of moms have vaginal dryness, genitourinary syndrome of menopause. A lot of us have sleep disturbances and brain fog, which we of course chalk up to, and it is going to be impossible to separate them, right?
Right.
But we chalk those up to, the baby and waking
baby
up
crying, right.
and all of those things and not sleeping, which again, you can't really kind of differentiate. But like, what about the night sweats and the hot flash? Do you wake up? Like, I remember breastfeeding, like during those times, waking up sweating. You're in a low estrogen state, okay? So you're in a low estrogen state, so it feels like a little, mini menopause.
And the postpartum blues.
Postpartum blues as well.
What's
happening?
What's happening there with your hormones?
So, a lot of, you can look at this with the different lens of either like it's a huge adjustment. Now all of a sudden you're a mom and there's a baby, but also you're losing all that serotonin. It's just getting sucked right out of you, right? We talked about that. So it's like not far off to say like our physiology is also playing a big role. Like sure, there's an adjustment period, but I think for far too long we've thought like it was just postpartum, and postpartum is this like very special, unique state. No, it's just like menopause, right? It's very similar.
100%. So I tell people that, yeah, if you have been postpartum, if you've been breastfeeding, that's like a mini menopause state. And so here's an important question. What are your thoughts about progesterone therapy in postpartum?
Yeah. Well, in my group where I have clinicians, they've started to ask each other questions about using menopausal hormone therapy postpartum.
Right.
So now let's go back to a topic we talked about before. I don't know if this happened to you, but it definitely happened to me. I just had my baby at Ohio State because that's where I was working at the time. And the resident comes in the next morning and asks me, what will be my birth control or method of contraception when I go home? Now, so here's the thing, right? This is again where it's acceptable to talk to women about birth control and that
giving hormones,
because the benefits of not having another pregnancy right away, and again, making sure that those babies aren't too close together. And then what about the breastfeeding and how much does it decrease breast milk is something people do think about, but many women are given birth control pills on their way out, or an Explanon or an IUD or whatever it is, right? And so what about the use of postmenopausal hormone therapy in the postpartum period? The first question is it safe? Probably just as safe. You just went through probably the highest risk period of your life.
With all those hormones, yes.
The next 6 weeks are probably also pretty risky in terms of blood clot risk. But again, we may be thinking about progesterone, not estrogen, because progesterone does not increase risks of blood clots.
Nope.
That's the estrogen, right? So could you use progesterone postpartum? Why not?
Absolutely.
You certainly could.
You certainly can.
The main thing to think about is, does it make you too sleepy? You don't want to maybe like sleep through the baby's crying, but also maybe sometimes you do if you have a partner who's going to help you that one time.
If it's my turn to sleep tonight.
It's your turn to sleep.
Maybe I do need that progesterone.
The other thing that I widely prescribe postpartum is vaginal estrogen.
Right, there's dryness because your estrogen is low. Your skin is dry. Your facial skin is dry. I mean, basically all the symptoms of menopause. Yeah. Also, most people don't know that postpartum, you can also lose bone density.
Yes.
It does come back for most people, but you're also losing bone density.
Yeah.
So here we are after we give birth in a mini menopause, and there's also room for hormone replacement therapy like progesterone in that period that we are not talking about enough. So thank you for being here and talking to us about perimenopause and I guess even postpartum phase.
You got it. It's so fun to think about the similarities as like from your first period, to postpartum to perimenopause, because even your first period, your body's kind of waking up. How long does it take women, I always talk about, to start having regular periods? Well, sometimes 5, 6, 7 years. Sometimes you're not in college till they're regular. How long does it take for the opposite, for you to switch your body off in perimenopause? 5, 7 years, right? Same process, just different, right? Postpartum is a mini menopause. These things are not wildly different. And I think thinking about them as like sideload things are just for OBGYNs, or maybe this is, the diabetes is just for internists and endocrinologists. But what about the migraines and the UTIs? And what about the itchy ears and the dry skin and the vertigo and the palpitations? Every specialist is going to see women in menopause, maybe besides 4 pediatricians. But it's important for everyone to know a little bit about it, because in your specialty, you will probably see some women coming in and what their experience has to do with their change in hormones.
You are 100% right. And it's also important that if somebody comes in, not to say, well, this is perimenopause, because there are other things that could be coming into play in your 40s, making sure you're checking their thyroid hormones, looking out for other autoimmune diseases, because those do tend to creep up in perimenopause.
Yeah, it's like the unmasking of all the things.
Unmasking all the things that are happening.
Yeah.
Well, thank you for being here.
My pleasure.
I loved this conversation. And you had a book come out. So can you tell us a little bit about it?
Yes, I recently wrote a book called The Perimenopause Survival Guide. It's great for clinicians. It's great for women. And I'm so proud of it because going through perimenopause now myself, I mean, there's little bits and pieces of like me and my story in there, like the rage and the yelling at your kids and, you know, all of those things. But again, I think this book was so important because menopause has been having a moment. But perimenopause is like menopause's evil little sister. I said little sister, my patients say evil little sister. And again, if we can educate women now about what's happening to their body, as soon as symptoms start, then they won't see 3, 4, 5, 6, 7 different doctors. They won't go get unnecessary testing. They'll be able to figure it out, pinpoint their problem, and then target their solutions and get relief.
And get treated. Yeah. 100%. Well, thank you.
Thank you.